Fun.
Hilang.
Trial.
Aja kan?
Assalamualaikum.
Salam, Shanti. How are you doing?
How are you?
I'm alright, Alhamdulillah.
Alhamdulillah. Thank you so much for your coming.
Yeah. Thanks to you too for your invitation.
Okay. You're welcome.
I don't know whether I should start straight away or you will say something before I start.
Yes, a little bit greeting.
Yes, okay then.
Yeah. Bu Kiki sudah masuk?
Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, everybody. Welcome to the guest lecture, December 1st, 2020. Please turn off your audio. The respected, the head of nursing study program, Mrs. Santi Wardaningsi PhD, the respected Dr. Siti PhD as the speaker for today's guest lecture, and all students of nursing study program UMY 2019. First of all, I'd like to introduce myself. So my name is Aisha Gansanansari. I am as the moderator for today's guest lecture. Before we start the guest lecture, let's open the agenda by saying Basmala together. Bismillahirrahmanirrahim. Ladies and gentlemen, I would like to invite the head of nursing study program, Ms. Santi Wardaningsi PhD, to deliver her opening remarks. To Mrs. Santi Wardaningsi PhD, the time is yours.
Ya, thank you, Aisyah. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin wassalatu wassalamu ala asrofil anbiya'i wal mursalin wa ala alihi washabihi ajmain. Rabbi shrah sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. First of all, let's pray to Allah Subhanahu wa Ta'ala for all the blessing and health that give to us. salawat and salam given to our Prophet Muhammad Sallallahu Alaihi Wasallam. The Honorable Dr. Siti Roshaidai, PhD, as our speaker, and the Honorable Ms. Norvita Ristiana and Mrs. Rizky Octavia as the lecturer in UMY today, and also all of the students in your room or in your place today. Thank you for your coming. The special I give to Dr. Siti Roshaidai as our speaker for our class in block maternity nursing. Yes, Dr. Siti Roshaidai is my dearest friend from IUM. Our university actually have the long collaboration, which is in lecture, education, and also in research. So we hope our collaboration will be continue day by day. And for the student, we hope the lecture from Dr. Siti Roshaidai, if I'm not wrong, for 3 times, yeah. 3 times Dr. Siti Roshaidai will give to you the topic, the lecture in maternity nursing. She is very well in her major, especially is in maternity nursing, and we hope you will get you can ask anything, you can discuss with her in the topic. I think it is enough for my remark, and please enjoy the lecture. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much to Mrs. Andrea Binti for the opening remarks. Before we start with the main agenda, I'd like to introduce our speaker for today, Dr. Siti. I'd like to our speaker for today names is Dr. Siti Roshaidai Binti Muhammad Arifin, PhD. She is the assistant professor at the Department of Special Care Nursing, Kuliah of Nursing at the International Islamic University, Malaysia. Her academic qualification on 2016 is as post-basic in Maternity Ministry of Health, and also she received her Bachelor of Health Science in Nursing with honors at University of Science Malaysia on 2000. And then she pursued her Master of Nursing Science at the University Malaysia at Kuala Lumpur, and then her PhD program in Nursing and Midwifery at the University of Stirling of United Kingdom. So without any further ado, I'd like to invite Dr. Siti Roshaidai, PhD, to deliver her material for today about trend and issue in maternity nursing. To Dr. Siti, the time is yours.
Thank you so much. Bismillahirrahmanirrahim. Rabbi shrahli sadri wa yassirli amri wahlul 'uqdatam min lisani yafqahu qawli. So first of all, thank you so much for the invitation for Dr. Shanti as well as Miss Dina. I really appreciate the experience that you give to me today to share with your students. I have seen the list of your students is quite many. I think 97, so almost 100 students here. So it's a big number for me. Normally in my class, the maximum is about 80, 83 students like that. So you are more bigger than us. So I just would like to clarify if I should, there's echo here. I don't know.
Your voice is clearly.
Clear. Okay, good then. Should I share my slide here or Dina will share on my behalf? Should I share my slide here? Because I cannot share the slide now. They said host disabled
Bisa
participants.
dijadikan co-host Mbak Ais. Siti, before you continue, maybe I will left earlier because we have the ISO Monef.
Right.
So I can join your lecture until finish.
Yeah, it's fine, Shanti. It's fine. Feel free to do so. Just Shanti,
Okay.
before you leave, I just like to clarify. They are now in the third year student, or what year are they?
Yeah, third year student.
Third year student, and this is the first lecture on maternity?
No, they already get another topic. Maybe Bu Kiki can explain. Bu Rizky or Mrs. Rizky is the coordinator of maternity nursing. Bu Kiki ada? Bu Kiki. Bu Rizky masih mute ya?
Yes, Bu Santi.
Ya. Sebelumnya sudah mendapatkan belum, Bu? This is the first, no kan? Before this lecture, the student already get another topic, right? Bu Kiki, your voice is not too clear. Kayaknya ada echo-nya ya, Ais ya? Bu Kiki? Mana? Bu Kiki suaranya.
Sinyal saya.
Ya. Suaranya ini ya, Bu. Bu Kiki ini sebelumnya sudah dapat kuliah kan?
Iya.
Iya. Ya. No, not the first time, but this is the students have already get another topic.
Yes,
Yeah.
two meet.
Oh yeah.
All right. I'm glad that I'm not the first one who teach, because I'm going to use a few terms that might not. I'm afraid that if the student not familiar with that. So if the student already have some lecture, then I assume they already well versed with that term. Okay, good then, good. So I'm struggling to share my slide now. I don't know whether. Yeah. Okay, now I can share. So
okay,
I guess,
yeah,
you can see my slides now, yeah?
Yeah.
All right, thank you so much. Okay, good. So can I start now?
Yes, of course.
Yes, thank you so much. Thank you so much. So, dear all students that I really love to speak to you today. So before I begin, let me introduce myself, even though the MC just now already tell a little bit about myself. So my name is Siti Roshaidai. I'm currently working in International Islamic University. So as Dr. Shanti mentioned just now, my major area is the maternity nursing, or obstetric, or the area of maternal mental health. So I have been teaching this subject since 2000, I guess in 2006 or 2007, on and off. So I went off for my study and come back here and there. So I'm really glad to see your topics. It's not that different to my course outlines or my topic as well, except for the topic of trends and issue in maternity nursing is something new for me. So I would like to say this is the first time I talked about the trends and issue in maternity nursing, but don't worry, this is the area that we are well versed, so hopefully we can have a look together. We can share whatever we think is beneficial to others today, inshallah. Yeah, right. So in this lecture today, I'll be speaking on these five topics. Yeah. So the first one is the contemporary childbirth, and after that, we're going to move to the culturally competent care. And then we're going to discuss a bit about the special issues that relate with the ethical situation in caring for pregnant mother, in caring for postnatal mother. And towards the end, we are going to see the statistical data and maternity infant care, as well as the evidence-based practice. I believe that you all well versed with this evidence-based practice, but today we're going to focus more on the maternity nursing, inshallah. Yeah, right. So when we talk about the contemporary childbirth, we understand that the pregnant mother and their family cannot be separated. And with the advancement in terms of the scientific knowledge and the technology, we still believe that family is part of the woman's life. Therefore, nowadays there are policy that has been moved towards involvement of the family members in taking care of the pregnant mothers, for example. So in Malaysia, we allow the husband, for example, to come in during the childbirth process. So we allow the father to come into our labor room, allow them to accompany their wife throughout the labor. I believe that in Indonesia, perhaps the same. In certain countries, they allow the other family members to join in. For example, after the mother already give birth to the baby, they allow the siblings to come in and enjoy the moment of being a new brother or new sister, for example. But it depends on the setting of the hospital. For example, in Malaysia, we don't allow the kids below 12 years old to come and visit at the hospital. So in this situation, the siblings which their age is less than 12 years old, they are not allowed to come and visit their new baby, new brother or sister. All right. So we know whatever the condition is, our contemporary childbirth should involve the family in terms of giving the nursing care towards the pregnant mother, as well as for the postnatal mother. In the area of maternity also, there is increasing number of choices about the aspects of childbirth experience, whether or not the mother wants to give birth at home, they want to give birth at the hospital, for example. Even though in common situation, we as a nurse or as healthcare providers, we will encourage giving birth in the hospital instead of home, because we understand that in hospital, if anything happens to the mother, we have ready what we call intervention. We have the advancement of technology in the hospital. We have the expert that is working in the hospital so that we can provide the immediate healthcare if there is any complication occur out the childbirth. But some women, they really insist to have home birth, for example. So in this case, we as a healthcare provider have to educate them in terms of the bad and good, the pro and cons if they give birth in the hospital. And then some women, they also have the preference toward the caregiver that going to take care of themselves during the childbirth process. For example, in Malaysia or in a Muslim culture, always, the female or the husband, for example, the husband always argue that their wife should be taken care by the female doctor instead of the male doctor, because they said this one is aura, the male doctor cannot see the aura or the perineum part of the wife, so they have to take care. The wife have to be taken care by the female doctor, so they don't want the male doctor. But until now, we don't have the luxury to have all female doctor in the lab room. There's a situation where we need male doctor to come in. Yeah, even though we as Muslims, for example, we also want to take care of the female patients instead of, we don't want to expose ourselves to male, for example. But in this situation where the situation happen, we need to take care of the male patient as well. So in this case, the patient need to understand the situation. Right, and then after that, we also have in the contemporary childbirth, we also have the high-tech model. For example, we have the epidural as a part of the pain management for the women during their labor process. And also, we have now electronic fetal monitoring. After this, I'm going to show you one picture, the advancement in terms of the technology for monitor the fetal heart rate while they are in the maternal uterus. Again, in terms of the contemporary childbirth, there's lots of information. You know that now the internet everywhere, people can access the internet from their house. Therefore, lots of information available in the internet, so the mother can access towards the information. There's a good thing and bad thing about this technology, whether now the information from the healthcare professionals are easily delivered to the mother at home, or the mother can get lots of information, can be true, can be false information, and then if they don't know, they might just take the what we call the false information in. So as a nurse, as a midwife, as a healthcare providers, we need to interpret this. We need to explain this to the woman outside there, which one is correct, which one is wrong. So we also need to be updated with the current knowledge, current issue in the maternity area. The other thing about the contemporary childbirth is that the interest toward the alternative or complementary therapy is still there. In fact, they are still they are growing nationwide. I don't know situation in Indonesia, but in Malaysia, we always like a postnatal mother, like after giving birth, many of these mother would like to take the what we call the jamu, the alternative medicine that they believe will facilitate the recovery or facilitate the wound healing. For example, if they have the wound after the delivery or after the childbirth, taking this complementary medicine or alternative medicine will fasten the wound healing. So, in certain conditions, the alternative medicine can result in neonatal jaundice. If, let's say, the mother is breastfeeding, at the same time taking the alternative medicine, the jamu things, and then this can be transferred to the baby and cause neonatal jaundice. So as a nurse, again, we need to be sure of this evidence and then be able to explain to the mother about the complication of taking alternative medicine during breastfeeding period. Okay, so normally we will say that, okay, after certain period of time, you can consume this jamu, but not at the beginning stage of the postnatal to avoid any complication to the baby, right? I don't know if you can hear me well, but I can hear echo of my voice. It's not comfortable. I don't know what to do. Any one of you also hear echo of my voice, or it's just me?
No, I don't hear any echo in your voice.
Yeah, so it's just me then. I don't know. What's happened? Right. Okay, it's no longer there. I guess because I on to computer, right? Okay. So
Right.
so let's proceed to the next one. So just now I mentioned about the advancement in terms of the technology, right? So these are the example of the situation. On your left, you can see the women lying on the bed, and attached to this machine, we call it cardiotocogram machine. This machine is used to check the uterine activity as well as to check the fetal heart rate. So in common practice in Malaysia nowadays, the mother in their labor room, they will lie on the bed, they cannot go to the toilet, they will attach to this machine, and this machine will record the fetal heart rate as well as will record the maternal uterine activity. And it might not be comfortable for the mother, cannot move as they want, yeah? So they attach with this kind of machine. This one is the common practice nowadays. This is what we want. This is what we practice so far. But here, on this picture, this one is the current technology that have developed the wireless patch system to monitor the uterine activity as well as to monitor the fetal heart rate. So when you use the wireless system, then the mother can move freely inside in the labor room. So they can go to the toilet, they can do the activity they want, right? So they can go pee and poo in the toilet as they want, and it's more comfortable for them. But again, this one is not yet practiced in Malaysia, but it's available overseas. Yeah. So this one also will influence the practice in terms of the contemporary childbirth. Right, so now we finish with the first section. Now we move to the next section regarding the culturally competent care that we have in the area of maternity nursing. So what is culture? So we know that culture is developed from the social, okay, the social belief, the lifestyle that we have, the values and integrated patterns of behavior that are characteristic of the family and the family or cultural group or a community. So different culture, they will have perhaps their own belief, their own lifestyle, and their own values or their own behavior, or perhaps your culture might be a little bit with our culture over here. And we understand that the cultural background and values of childbearing family are often quite different from those nurses. Okay, many of my students now, they are working in Saudi. So they went there for, of course, for new experience, for great working environment, as well as for the luxury of the salary. They got 10,000 ringgit Malaysia per month, for example. That's quite a lot, higher than my salary. So they're working over there. But they have to understand taking care of patient in Saudi, of course, will be different compared to taking care of patient in Malaysia. And the Malaysian culture would be different as compared to the Saudi culture, right? So in this case, the students or the nurse should understand their culture, the patient's culture. To understand this, the nurse might want to consider the special elements that will develop or that we contribute to the family's value system. Right, so we understand that in our family, for example, the religion that we have, the religion that we follow, and our social belief will contribute to our family value system. Yeah. And then after that, the presence and the influence of the extended family members also will contribute to the family value. For example, if you are living with your grandmother, or you are living with your grandfather, of course, your family values would be different as compared to those who only live with parents, with a mother and father only, right? So normally in this case, their understanding, their rules and regulation within the family members will be affected by the older generation. Older generation will say that, okay, you cannot do this, you cannot do that. If you do this, what happened? Pregnant mother, you cannot eat this. Pregnant mother, you cannot eat that. After deliver, oh, you cannot eat lots of veggies, lots of vegetables. For example, you cannot drink lots of water after you give birth. This will make your uterus become watery, for example. Okay, and you might got some bleedings for that. So this one is the values, the cultural things that the nurse should understand when they are living with the older generations. Their understanding, their values might be different. Yeah. And at the same time, the communications patterns in the family also can contribute to the woman's understanding of the disease and illness, for example. Yeah. Nowadays, we have the technology, the communication patterns where if you are living in double-story house and the mother is downstairs preparing for dinner, and the kids are upstairs doing their homework, for example, and you don't want to shout, hey, all my children come down. You don't want to shout like that. Now you just use your phone and just post in your family group saying that dinner is ready, come down and eat together, right? So that's why it's the communication using the internet, using the phones, for example, to be together and to eat for dinner. So that one is the different communication in the family. And also the culture that we have within the family, the belief, the understanding about the concepts of health and illness also important, right? For example, some people, they might understand that pregnancy is not an illness. Pregnancy is, I always say to my student, pregnancy is not illness, but it is the illness that caused by the husband. The husband that makes the woman get the illness, and the illness is the pregnant. Right? So if they think that the pregnancy might, yeah, I know that pregnancy, we may not want to consider the pregnancy is an illness, but we understand that pregnancy is carrying another life inside your body, which you don't know the condition if you not see the professional, if you don't see the professionals. So in this case, if you understand the pregnancy is a natural process, some people, they understand, okay, pregnancy is natural process, so there is no need for me to go and see the doctor. Then I just stay home. I didn't follow the antenatal care. I didn't follow the any treatment given to the pregnant mother, for example. So some culture, they might understand in that way. But if you understand, okay, pregnant is not an illness, but we know that we are carrying another human life inside our body. Therefore, we need to go and check if there is anything abnormal to the another human life that we are carrying now. So then we will follow the antenatal care. All right. And another issue about the family value system is that the permissible physical contact with the strangers. As I mentioned to you just now about interaction between the male and female. Female patients comes and the male doctor will take care of the female lady. Then now there's a concern if, let's say, we are talking about the Muslims culture, when you want to touch, when you want to physically touch the opposite gender. If you are male doctor, you want to touch your female patient, then you need to ask their permission, right? Or in certain culture, they might want to chaperone to comes in. So the husband, the mahram, will be there and to see the process of the treatment or whatever assessment that you do to the patient. And then the education that the mother receive or the women receive also will influence how they will be receptive to our care. Educated mother would be quite different to less educated mother. The urban mother who live in the city area would be different for as compared to those in the rural area, of course. Yeah, the educated and non-educated or less educated group will have their different culture. And then there's also specific elements that makes that one in between the family. But now we are talking about the differences between the culture that the family have and the culture that the healthcare providers might have. For example, in terms of help-seeking behaviors, in certain what we call in certain case where a woman might have some problems during their pregnancy. Some of them might say, okay, this one is okay, I can manage it, I can handle it, this is my personal problems, I no need to see the doctor, I got a small bleeding only, that's not important, no need for me to go see the doctor. But for the healthcare providers side, they might say, even small bleeding during the pregnancy, you need to come and see the doctor. You need to check if there is anything serious about your pregnancy, right? So this one is the what we call the conflict or different opinion between the family and healthcare providers. Or just now I mentioned about the family who prefer more on the traditional treatment. I don't know in Indonesia. In Malaysia, traditional treatment is always there, especially in Malay culture, right? So they might say, oh, I need to go to see the traditional healer first, check whether or not it's okay. Then only if the treatment, if the traditional treatment or traditional healers fail to treat my condition, then I will go and see the doctor or I will go and see the nurse, right? So that's in terms of the help-seeking behavior. And again, if you talk about the differences in terms of the pregnancy and childbirth practice, there's a lot. I have been doing research on postnatal depression. Dr. Shanti is part of my team in doing this research as well in Malaysia. Right. So in lots of my patients, they have depression because there's conflict between what have been advised by the family members and what have been advised by the healthcare providers. Okay. For example, in Chinese community, there's a woman who said that, okay, you no need to breastfeed the baby. You no need to breastfeed the baby. You just give the formula milk because when you don't have enough milk to give to your baby start to cry, and then your baby hungry. So better for you to give formula milk only. No need to give the breastfeeding. Why you so bothered about the breastfeeding? When now you have the formula mix is ready for you, for example. But the healthcare providers always say, oh, mother, you need to give breastfeeding to the baby since the delivery until 6 months of the childbirth. WHO said that this one, what we call exclusive breastfeeding. You should give breastfeeding only for 6 months after childbirth. And now the mother really motivated to give the breastfeeding. Okay, they're really motivated to give the breastfeeding. But the mother-in-law say, no need lah, just don't give the breastfeeding, just give the formula. Why bother to give the breastfeeding? They will say like that. That's how Malaysian talk lah. And then the mother will feel conflict. Okay, the nurse tell me to breastfeed the baby. Now parents say, or the mother-in-law say, no need to breastfeed the baby. Which one should I follow? Which one should I follow? So in this case, there's a conflict until at one time with the other factors, then she get depressed because of that condition. That's the example. And then causes of the disease or illness. As just now I mentioned to you, how do you perceive the pregnancy itself, whether or not it's an illness, whether or not it's a natural process, or whether you are carrying another human's life inside your body. And how you being acceptable, how acceptable you are when the death and dying occur. I give you the example. If let's say the mother lost the baby after giving birth, right? It's so sad. The moment is very very tragic to the mother, okay? And the mother, whether or not they can accept the situation. For the mother who can cope very well, it's fine. They will say, okay, this is the destiny, this is the qada and qadar, this is what Allah have decided to me, this is what Allah or the God asked me to face, and I will face it confidently with the support from the family. I will recover, I will accept it. But for certain people, the death and dying are quite hard for them, okay, quite hard for them, and they struggle to accept the loss of the baby. So it's different, okay, from one culture to another. And also the process of caretaking and caregiving. This is quite interesting when you are taking care of the mother, yeah. They always believe that when you first time having baby, then the whole family should be there. Mother-in-law come, the biological mother also come, auntie, uncles also come to see the baby, take care of the baby, right? But at the same time, perhaps, yeah, another culture, they are quite lonely, especially immigrant mother who live in different country, for example. They're quite lonely, so therefore they don't have any support system there, right, to take care of themselves after the giving birth. Right, so I guess we are done with the second section about the culturally competent care. It is important for the nurses to understand the culture of the family so that they will understand more and that involve the family members if is needed throughout the nursing care or nursing treatment. All right, so we finished with the second. Now we move to the third one regarding the special ethical situations in maternity care. I'm going to discuss about 6 topics in the ethical situation in maternity care. So first we will see the maternal fetal conflict. Then after that we move to the abortion. I believe that you have learned about the abortion, of course. And then we're going to see a little bit about the fetal research. And then after that, we move to reproductive assistance. And then we move to the stem cell and cord blood banking. This one is quite, what we call quite trendy, or the latest technology that we have, especially for the stem cell and cord blood banking, right? And then after that, we are going to see the implications for the nursing practice, yeah? So now, the first one, we would like to see the fetal conflict, right? The fetal conflict. So what is the fetal conflict? So fetal conflict refers to the situation that occurs when we have conflict of interest between which one we want to save first, whether we want to save the mother or we want to save the baby, right? So the maternal conflict, the maternal fetal conflict can occur in situations where the mother denies health recommendations. For example, the mother denies blood transfusions. The mother have anemia, for example, and the blood transfusion is required, but she doesn't want to receive the blood transfusion. Or in a situation where the cesarean section is required, but the mother refused cesarean section, they want to give birth through vagina birth. And also, this situation, we know that this, what we call this health recommendation, will benefit the fetus or make life choices. For example, those mothers who have an unhealthy lifestyle, like smoking, drinking alcohol, drugs, and other hazardous exposure, we know that if the mother drink alcohol during pregnancy, it will affect the development of the baby. For example, if the mother smoke during pregnancy, it will give a harm to the baby. For example, the baby might born prematurely, the weight of the baby is low during birth. The mother should know in this case, but we as a healthcare providers should advise in terms of the complications of this unhealthy behavior to the mother. So this one is the example of the maternal fetal conflict. But in this case, we always should remember whose life should be saved first. What if both have the same chance of survival? In this case, we have the conflict. To be clear with this example, let's have a look at this scenario. I have 3 examples here. So the first one is the ectopic pregnancy. So I'm not sure whether you have learned or not about the ectopic pregnancy, but I'm going to explain a little bit about the difference between the normal pregnancy and the ectopic pregnancy. So for the normal pregnancy, normally the fertilization will take place inside the uterus. So the pregnancy will happen in the uterus. Okay, but for the ectopic pregnancy, normally the fertilization does not take place in the womb or in the uterus. Instead, it takes place outside the womb or outside the uterus. Normally, it happens or it occurs at the fallopian tube. Okay, it happened at the fallopian tube. So if the pregnancy already advanced, for example, 3 or 4 months, at this time, we know that there's a fetus there, but at the same time, we know the ectopic pregnancy will harm the mother. Okay, so we know that during this stage, there will be inflammation surrounding the fallopian tube. There will be inflammation surrounding the fallopian tube. Therefore, it is important for the doctor to cut the fallopian tube in order to save the mother, in this case, right? But now, baby have the right to survive as well. Baby have the right to survive as well. But we know that the chance for the baby to survive for the ectopic pregnancy is not that high. And at the same time, it will bring complication to the mother, which is bleeding, for example, inflammation. And in the end, the mother will die due to the rupture of the fallopian tube. So in this case, there will be dilemma, the conflict whether to save the baby or to save the mother. That's the first example. The second example is about the eclampsia. What eclampsia means? What does eclampsia means? Eclampsia means the mother have seizure during the pregnancy. So the mother pregnant, but at the same time, the mother have, normally the mother have high blood pressure. So when the mother have high blood pressure, it also will comes with other problems such as they have protein in the urine. We call it proteinuria. Or the mother might also have the blurring of vision. They have the headache, they have the irritability. So in this case, it is important for us to save the baby as well as to save the mother, right? So there's a conflict over here as well. We're going to see after this. Also, we are going to discuss a little bit if the mother have cancer during pregnancy, what to do to save the mother, to start the chemotherapy, to start the oncology drugs or the chemotherapy, or not to start the chemotherapy. So that's the conflict that the healthcare providers might have. So for the ectopic pregnancy, we already understand that the tube is damaged. There's inflammation at the fallopian tube to constitute a serious threat to the maternal life. So the maternal might not be survived if the fallopian tube already inflamed or already damaged. So therefore, we need to remove the tube or the fallopian tube. Otherwise, we will cause the trauma to the mother. Or in a serious situation, the mother might be die due to the damaged fallopian tube. So in this case, of course, the baby might not be survived. Okay, so in the case of eclampsia just now, so what could be done in this situation is we as a healthcare providers, as much as we can, we want to control the eclampsia using the medication so that the baby can be survived and can be delivered safely in the end, right? So if there is a situation become more worsening, become more worse, then we have no other choice accept to terminate the pregnancy and deliver the baby so that we can save the mother and give chance for the baby to survive. Okay, so normally for the mother who have eclampsia during the pregnancy, the condition will improve when the baby is born. Okay, so after the delivery, normally the situation will improve with the medication, with the treatment, then the condition of the mother will improve. So that one about the ectopic pregnancy, about the eclampsia. So now we move to the cancer. If we know that the mother have cancer, if let's say the cancer occur, or we know or we diagnose the cancer before third trimester, so you know that pregnancy is divided into 3 trimesters. The first trimester is the 0 until 3 months. The first 3 months we call it first trimester, and 4th month until 6 months we call it second trimester, and then 7 to 9 months or until delivery we call it third trimester. So if let's say we diagnose the cancer before the third trimester, which is during first or second trimester, the cancer is treated. We should treat the cancer. Okay, we should treat the cancer. If chemotherapy or radiotherapy is required, then we should initiate that treatment. And we know that the treatment of chemotherapy, of course, will indirectly or directly will affect the development of the baby, but we really allow it to happen. Okay, right. So when we know that the cancer happened in the third trimester, which is after 7 months of the pregnancy, we, as much as possible, we want the mother to continue the pregnancy until the end, until the term, which is 37 weeks. So 37 weeks, we say term pregnancy. So at this time, when the term pregnancy, then only we can terminate the pregnancy and allow the baby to be delivered and start the chemotherapy if it is required. However, if the situation becomes worsening, of course, we need to remove the baby. If the baby is already viable, if the baby is not viable, meaning that if the baby don't have any chance to survive, then we start the treatment for cancer. Right? Are you okay so far? Can you follow?
Yes, Miss.
Yes? Follow, eh? Am I too fast, or I'm speaking quite weird so that can you understand well?
Understand, Miss.
Understand, eh? Okay, good, good. Alhamdulillah. Let me know. Yeah, let me know if I'm going so fast. Should I slow down a bit?
Oke, kecepatan nggak teman-teman? Apa sudah
Enggak,
baik?
tidak Bu.
No, it's
Okay,
it's
okay
okay.
aja.
I don't know.
It's okay, just go ahead.
Okay, boleh sambung ya.
Boleh.
The bad thing about me, I don't know how to speak Indonesia, but I learned from Shanti. I learned from Shanti. Right. So as a physician, they have their what we call the rules and regulation that they want to follow when treating or when they have conflict, which one they want to save first, whether the mother or they want to save the baby. So when they want to assess the risk, the doctor or the physician should provide the mother or the patient with accurate observation of her disorder and known data gathering. What does it mean? It means that whatever it is, as a doctor, as a nurse, we should be frank to the mother. We have to tell the mother the truth, and we have to explain what is the observation that we got, what are the results or the findings of our assessment, so that the mother will understand. So that if they understand, they can do the decision wisely. All right, at the same time, the physician also should accurate as possible to quantify the benefits and the risks. For example, just now we have seen about the eclampsia. We have to explain to the mother what are the benefits of treating the eclampsia and what are the risks of treating the eclampsia. About the cancer just now, the doctor should explain, if I treat you with chemotherapy, what will happen to the baby. If I don't treat you with chemotherapy, what will happen to you? What will happen to the baby? So they should explain to the mother. And physician also should allow the mother to make her own decision, right? So it is not the physician to make the decision, but the decision should be made by the mother. Our responsibility is to explain what we think or what is our findings to the mother. At the same time, the family should also understand, especially the husband. Husband should understand. For example, in case of the ectopic pregnancy just now, we understand that when we remove one side of the fallopian tube, there's less chance for the mother to get pregnant, even though, of course, the mother has another fallopian tube. Okay, another, if let's say we remove the left fallopian tube, we'll still have the right fallopian tube. Still, the mother have chance to get pregnant. But this one should be explained to the family members, especially for the husband, yeah, so that they will understand. And in situation where the physician or the nurse, they have the conflict with the decision, they have the conflict whether or not to agree with the decision made by the patient. For example, patient say, oh, okay, just terminate my pregnancy, but they don't agree with that abortion, for example. This one conflict with their own personal values, they have the right to withdraw. They have right to withdraw from the case. Right, so but in order to withdraw from the case, of course, the nurse or the doctor should understand the institution value. So it is important for you to understand the values at your workplace before you make a decision to work there. I remember one of my students, she wants to work at the Singapore, but the hospital does not allow wearing scarf. Okay, wearing tudung is not allowed in that hospital. So she said, I better not to work at the hospital, otherwise I might not be able to cover my aura properly. So your personal values, have not should not be contradict with the institutional values. Otherwise, it makes you other problems in the end. So in an emergency situation, the physician should serve as a surrogate decision maker and exercise his therapeutic privilege. So it means that when emergency happens, at that time, the mother cannot make the decision, or the family said, okay, doctor, it is up to you. We will follow whatever your decision. So in this case, the physician or the doctor will decide on behalf of the family. Another issue is about the abortion. The ethical issue in the maternity area is about the abortion. So what is abortion? Abortion is the pregnancy that is terminated before 20 weeks of the pregnancy period, or we call it gestation. Or if the gestation is not certain, you're not sure, the mother is not sure whether 20 weeks or 24 weeks, the mother is not sure. In this case, it will rely on the fetal weight, the weight of the baby, which is less than 500 grams. We indicate this one is the abortion. For example, if the baby weight during the delivery only 400 grams, okay, so that one we consider as an abortion. So different people, different culture, different experience, different religion, they have different opinion about abortion. Okay? In Catholic Christian, for example, and in Muslim culture, we don't believe in terms of the abortion. Okay? We don't believe in terms of abortion. We believe that the mother should continue the pregnancy regardless of the baby's condition. For example, if the mother already know that the baby is not well, the baby might have some, what we call, the baby might have some congenital abnormalities. What we call congenital abnormalities like a Down syndrome. Should the mother abort the baby? So in a Muslim culture, of course, we are not allowed abortion in this case. Yeah. Right. So nurses have the right to refuse. I already mentioned just now. They have right to refuse if the abortion is contradict to their moral, religious belief, also ethical belief. So they have the right to withdraw from the case. Right. So this picture, this figure shows the legal grounds for abortion around the world. If you can see, the darker color indicate that that country not allow abortion to take place. For example, here, yeah, at this place, okay. And then this area, for example, permitted to save woman's life. The abortion is permitted to save woman's life at the area of African countries, certain area here. And for certain area with the lighter color here, for health reason or in case of rape. In case of rape, then abortion might be allowed. And for other country, like in the US, Canada here, the abortion is allowed for economic reasons or on request. So that's what we worry, if the abortion can allowed in any condition, or abortion can take place when the mother requests to have the abortion. So now we move to the fetal research. Fetal research is about the research that we do to study the abnormalities that happen to the baby. For example, here, the research that we do for the infants who have rhesus synthesized, the evaluation of the lung maturity using lecithin, the treatment of pulmonary immaturity in the newborn. So this one is the example of the research that relate to the infants, or relates to the fetus. For example, study about the HIV/AIDS. So this one, the study of HIV/AIDS, regarding, involve the fetus inside the uterus, yeah, the unborn fetus, yeah, the unborn baby. So some research, lots of research undergoing regarding the HIV/AIDS, regarding the biological developments, regarding the eye developments and disease, regarding infectious disease such as hepatitis C and diabetic type 1, as well as other problems inside the baby. So this research might be invasive in nature, which means that we might need to take the fluid, the amniotic fluids inside the tummy. So we need to prick inside to the uterus, of course, yeah. Right. So another issue that is quite ethical also is the reproductive assistance. So we know that the infertile couples, the couples who get married for 15 years, they don't have the children yet. Okay, so they want to get the baby. One of the steps they can do to get the baby is using the what we call in vitro fertilization, okay, or we call it therapeutic insemination. What does it mean? It means that we get the women ovum, okay, and then we mix with the husband's sperms, and then we mix it together outside, and then after that we inject into the maternal uterus. That one we call it in vitro fertilization, IVF. Okay, so IVF. Okay, after this I will have the picture. So if IUI, perhaps I might want to show to you the picture now so that you can see properly. So if let's say the IUI, the IUI, intrauterine insemination, so we take the husband's sperms, okay, we take the husband's sperms, we inject into the uterine cavity of the mother, and then we hope that the sperms will go and meet the ovum, okay, we go and meet the ovum. Prior to this IUI or intrauterine insemination, the women can be injected with certain hormones to make them more fertile so that the ovum will be produced more. So this one is IUI. Another reproductive assistant known as in vitro fertilization.
알아요. 깨도 안 줬어.
근데 왜 기다려?
그냥
Anything should I know?
역시나 알겠지만.
나 네 편 아니야.
Okay, yeah, just go ahead.
Okay.
Okay.
Thank you. So in vitro fertilization, this one we take out, the first step is we give the women with the hormone therapy. We want to stimulate the ovary to produce more ovum. And then after that, we inject at the ovary, and then we take out the eggs, or we take out the ovum from the mother. Okay, we take out the ovum from the mother. After that, we prepare the sperm from the husband. We get the sperm from the husband. After that, we fertilize the ovum and sperm. We mix them, and then after that, it will form the embryo. After they form the embryo, we will bring or inject this embryo inside the uterine cavity of the mother. So that's the difference between the intrauterine insemination and in vitro fertilization. So in this case, we know that in certain case, if the husband is not fertile, is infertile, for example, in certain culture, they allow the sperms to be donated by other men. Okay, so the sperms is not belongs to the husband, but belongs to another man. In this case also, if the sperms of the husband is not that strong or infertile, then the donator or other men also can donate their sperms. That, of course, in the Muslim culture does not allow in terms of donating the sperms. You can donate your shirts, you can donate your shoes, you can donate your bags, your handbags, whatever, but in Islam, you cannot donate your sperm, or you cannot donate your ovum. So again, there's an issue there regarding the conflict. If you are Muslims working in non-Muslim culture, there's issue over there. Other things about the reproductive assistance is surrogate mother or surrogate childbearing that occurs when a woman agrees to become pregnant for another woman or for a couple who are usually childless. Okay, this one is quite special. Husband and wife get married. They don't have the baby. Okay, they don't have the baby due to some problems, infertile, wife cannot pregnant, but they have the ovum. The husband have the sperm, the wife have the ovum. So what they do, they give ovum and they give the sperm. She gives ovum, he gives sperms, and they give their sperms and ovum to the mother and put their ovum and sperms into another woman. So this woman is not the mother of the baby, but they carry the baby. They carry the baby for this couple. So you see here, their bun, her ovum. Means that the recipe is belong to this couple. Okay, but this woman helps to cook the bun, helps to cook the bread. Yeah, so that's what we call surrogate childbearing. Of course, again, in Muslim culture, we don't allow this surrogate childbearing. Another new technology is what we call embryonic stem cell. So we know that the human stem cells can be found in embryonic tissue, which is in the unborn baby. And this cell, we call it primordial germ cells of a fetus. So research demonstrated that in tissue cultures, these cells can be made to differentiate to other types of cells, such as blood, nerve, heart cells, which might then can be used to treat problems like a diabetic, Parkinson, Alzheimer, spinal cord injury, as well as metabolic disorder. So which means that using this stem cell will help us to settle other problems later on, like this problem here lah, spinal cord lah tadi, and then also the metabolic disorder. Excuse me. Do you normally take a break before we stop, or you can always continue? How do you normally do it? Should we stop or should just continue?
Just continue.
Just continue.
Just continue.
Okay, as you wish. Yeah, I will continue. So these stem cells is quite a new technology that being using to treat other disease, other disease such as here you can transplant, you can do the cells transplantation for bone marrow to treat leukemia, and can be used also for chemotherapy. Okay, you can transplant the tissue at the nerve cells to treat the Parkinson or Alzheimer disease. You can also transplant the cells and tissue to treat heart disease. And then you can also transplant the cell and tissue at the pancreatic islet cells to treat the diabetic, for example. And lots more coming with the research and technology, the advancement in research and technology, lots more will come. Another thing is about the blood banking. Okay, the cord blood banking. What does cord blood banking means? This means that we take the umbilical cord from the newly delivered baby, and then this umbilical cord will be used later on to treat other disease such as leukemia, cancer, metabolic disorder, or any immune disease, the blood system disorder like a sickle cell anemia, thalassemia, and also severe aplastic anemia. So you can use the cord blood that you have restored earlier to treat the disease later on. If let's say the baby, when they grow up and they have this kind of disease, you can go at the bank, collect them, and use back the cord blood that you have stored earlier to treat this disease. And you have to know also that the cord blood banks that store the cord blood have been established in the US. Okay, so the public banks receive cord blood given on a volunteer basis and are designed to support unrelated donor transplants program. So this one, if you see how it's done, yeah. So this one is the baby, newborn baby. They born with the umbilical cord here, right? So they have the umbilical cord, they have the placenta attached. After the delivery, we will clamp the cord here and here, and then we will cut. We will cut it, and then we put in the specific or special collection bag. We put it here, and then we send to the examination and analysis of the blood, and then we transfer it quickly to the lab or laboratory. We send it to the laboratory, and then we keep it there, we store. We have the special container for the cord blood bank, for the cord blood, and then after that we keep in liquid nitrogen storage tank inside the secure facility to keep it. So later on, after few years, the baby can come back and get their blood over here. Okay, can get the blood over here in order to treat the disease that I mentioned just now. It is quite interesting also to share with you in IIUM now, over in Malaysia, we are now want to establish human milk banking. Okay, human milk banking, where we are going to collect the breast milk from the mother, and we want to store in our bank, and then after that we are going to give the milk, the breast milk, to the other baby who need for the breast milk. So that one we are going to follow exactly the Islamic rules so that it become halal, it's not haram. Previously the human milk banking is not allowed, not allowed in Malaysia. But now we are moving towards halal, make it halal, in terms of giving breast milk from one mother, which is not the mother of the baby, but we donate the breast milk to another baby. Right, so what are the implications for the nursing practice? So there is a complex ethical issue facing maternal or the maternity nurses that we know that involved with the social issue, cultural issue, the legal issue, as well as the professional ramifications. Yeah, and the nurses also, like other all healthcare professionals, they need to learn to anticipate ethical dilemmas and also to clarify their own positions and value related to the issue, understand the legal implications of the issues, as well as to develop appropriate strategies for ethical decision making. So most of the nurses, they should have their own specific knowledge. They have the logical thinking. they have the critical analysis to analyze situations so that they can make a wise decision if they facing any conflicts in terms of the maternal fetal conflict, or in terms of the bioethical issues that they have just now, like abortion, like cord blood banking, or other issues that we already discussed just now. Yeah. All right, so now we finish with the third title. We now move to the fourth title, which is regarding the statistical data and maternal infant care. So first of all, in this one, we are going to discuss about the birth rate, and then we're going to move to the infant mortality and maternal mortality. And after that, we're going to see the implications for the nursing practice. I hope you are still okay, can still catch up. Birth rate. So birth rates refers to the number of live births per 1,000 people. So nowadays, our birth rate is increasing, increasing from the 90s to 2010. So 2010, the birth rate is increasing. But we are worried about the non-marital birth rate, which is unmarried birth rate. So unmarried birth rate meaning that you are not married, but you get pregnant and then you give birth to the baby. So we are worried about the welfare of the baby if the baby being abandoned by the biological mother. So the next one is the infant mortality. What does infant mortality means? Infant mortality means that the share of the children, the baby die before their first birthday. Okay, before their first birthday. So you can see that there is where is the okay, let's see this one. I got this one from the World Bank in Indonesia. Yeah. So this one, the infant mortality rate from 2009 to 2019. So the infant mortality rate seems to be decreasing, which is good signs. Which is good sign. So we want the mortality rate to become lower with the advancement of the technology, because we know that the infant mortality rate is one of the health indicator. The lower the infant mortality rate, which means that your healthcare system is much more better, right? So this one is the infant mortality rate in 2014. So this one is the latest one, this one up to 2019. So this one in Malaysia, if you can see here, okay, 6.6, the blue black color. So the Indonesia is the orange one, 27.2. That's the infant mortality rate in Indonesia in 2014, and Malaysia is 6.6 in 2014. Yeah. So what are the causes of the mortality rate for the baby? Okay. These are the common causes of the mortality rate for the baby, such as congenital malformations, the disorder, the sudden infant death syndrome, and the accidents. That are the most common one. Okay. All right. So now we move to the maternal mortality. So what does maternal mortality rate means? It means that the number of the maternal death per 1,000 live births during a given period. Okay, during a given period. So these are the example of the maternal mortality. Maternal mortality is also another health indicator, which means that we want the lower maternal mortality rate, so it indicates that our healthcare system is better and improved. So this one is the comparison between countries in Southeast Asia. Brunei, Indonesia, Myanmar, Philippines, Vietnam is here. So you can see the Myanmar about 282, the maternity, the mother who died after their giving birth in 2015, yeah, the maternal mortality. During their pregnancy or during their what we call during childbirth or after the childbirth, yeah. So where is Indonesia? So here Indonesia about 190 mother passed away during their pregnancy or during their childbirth or after the childbirth in 2015. Yeah, right. So the best one in Singapore, you can see Singapore only 2.4. The rate is only 2.4, which is good. Which is good to indicate that the maternal mortality rate is less. So what are the causes of the maternal mortality, or what makes the mother die during their pregnancy or during their childbirth or after giving birth? So one of the common causes is the hemorrhage, the excessive bleeding. It can be antepartum hemorrhage, which is occur during the pregnancy, or it can be postpartum hemorrhage, which occur after giving birth. The other causes is the hypertensive disease. Okay, hypertensive disease can be hypertension during pregnancy, or hypertension which leads to the eclampsia, or which leads to the preeclampsia that I already mentioned in the beginning of the lecture, infection, abortion, and other direct causes and indirect causes. Right. So what are the implications for the nursing practice if we know the maternal mortality rate lah, the infant mortality rate lah? What are the implications for us? So by understanding the statistical data just now, we can determine the population at risk. Okay, which are the maternal that having a risk of hemorrhage, for example, then we can take care of the woman having that risk. We also can assess the relationship between the specific factors, establish databases for specific patient population, determine priorities in caseloads, as well as estimate staffing and equipment needs for the hospital units and clinics. This one is so important for the Ministry of Health. For example, if we know that the mortality rate is high, then perhaps we need more staff, we need more staff which is trained with the maternity understanding or maternity knowledge to work in the hospital. Right, this one is the last one. I guess the last one. Okay, this one is the last one regarding the research in the area of maternity. So working in the maternity area, we need to base on the evidence that found from the research. So research is very important, so that when we want to develop certain policy, we will base on the research evidence. So we will follow the research findings instead of just doing policy like that without having any fundamental knowledge of the policy. Yeah. Right. So here is the hierarchy of the scientific evidence. So I don't know whether you have learned in your research methodology regarding the scientific evidence. So if let's say the research, the findings is from the case report, we consider this one is the weakest evidence. So the strongest evidence will comes from the meta-analysis or the systematic reviews. What does it mean? It means that the combination of many studies that you already learn, you already understand, and then based on the many studies, then only you will develop certain policy in terms of the maternity care. This one is the scientific methods. The non-scientific evidence, like the one that you have used, you know, from the YouTube, from gut feelings, the instinct, from the guy that you know, that one is not scientific, of course, yeah? Right, so this one is the example of the research that can be done in order to understand the factors influencing planned home birth and outcomes. For example, just nice to know only, can read later. Right, so last few issues that you would like to know or would like to discuss here also regarding the transgender and pregnancy. So this one is Miss Thomas Betty. His name is Thomas Betty. He's a transgender man. He previously a man. Then he later on changed to he previously is a woman. Okay, a woman, and then changed to a man. After that, he get married. Of course, get married to a man lah, who also transformed from a woman to a man, and she transferred from a woman to a man, then get married to another woman whatsoever. I got dizzy with the terms. And then after he got married, then he got pregnant. When he want to transfer or transform from human to the man, he decided not to remove the uterus. So he doesn't remove the reproductive system. So he still have the uterus. And then finally, when he get married, he got pregnant. 3 times he got pregnant. So this one is the issue, quite new issue. This Thomas Betty get pregnant, I think the first pregnancy in 2007, about 13 years ago. But nowadays, we got lots more of male pregnancy when men get pregnant. Nowadays, not only female get pregnant, but also men can get pregnant too. So this one is the current issue in terms of the maternity area lah. Yeah. All right. So another issue in Malaysia, I don't know whether Indonesia is that. Yeah, I've Googled the doula in Indonesia as well, and they say mau nyaman saat melahirkan, ayo coba jasa doula. So doula, what is doula? Doula is the people, normally lady lah, accompany the mother during the childbirth process. Okay, so they accompany the mother during the childbirth process. So lots of argument, lots of issue in Malaysia. We discussed in the national TV regarding whether or not the doula should be there to accompany the mother during the childbirth process. And recently, in 24th November, our government have said that the doulas who are not recognized as a midwife should be banned from giving the medical advice, because there are lots of issue regarding the home birth and doula. So the government have banned the unregistered doula to give the advice for the pregnant mother. Right, so the last issue is regarding the maternal mental health. So mental health for the pregnant mother, mental health for the mother who already gave birth. So we know that lately the issue of depression, anxiety are increasing over the world, across the world, increasing of the mental health issue. And this also included in terms of the pregnant mother as well as the postnatal mother. So 1 in 5 mother will suffer from maternal mental health disorder like postpartum depression. And only less than 15% the women go and seek help. Right, so many of them did not go and seek help, and this will later on give complication to the baby's development as well as for the maternal safety. And then 1 in 7 will experience depression during pregnancy. 50% women living in poverty will suffer from maternal mental health disorder. And not just moms, father also can get depression. Maternal mental health disorder impacts the whole family, not just a woman. Father also can get depression as well if they are living with the mother who have depression. Okay, so right, more than 600,000 women will suffer from a maternal mental health disorder in the United States every year. So it is increasing. Anxiety and depression have risen 37% in teen girls. And this will increase the number of women suffering from postnatal depression in the future. Yeah. So 1 in 10 deaths also have depression after they have the first baby. Right? Okay, that's all for me. Thank you so much. I don't know what is your feedback. How do you feel about my lecture? I hope that you can follow very well. Thank you so much. I know that we have another lecture on Friday at 3. I think at 3. So this is my contact number. If you'd like to call or if you'd like to email to me, here is my address. Also, we have the website that you can know further if you like to go to the website as well. Right, thank you so much. I welcome any question if you have. Thank you.
And Dr. Siti, thank you very much for the material for today. I guess that you will have the guest lecture on Friday at 2 p.m. I guess.
Okay, all right.
Friday.
Okay.
Right.
Yeah.
So, teman-teman yang mau bertanya silahkan. 3 orang penanya.
Mau tanya, Bu?
Okay. Go ahead.
Yes.
Okay. Should I say it in Indonesian language or English language or both?
I guess English is better because I'm afraid I don't understand.
Okay.
The term.
Okay. In the past, when I practiced clinic at the hospital, I found a case of a pregnant woman who had seizures with a pregnancy age of 7 months. The mother had 4 seizures, and after being examined, the baby had died. So, in this case, I want to ask, how did the baby die and what condition caused the mother to have seizures even though she had no previous history of epilepsy?
Okay, right. So always the eclampsia, like I mentioned just now, eclampsia during pregnancy is always related to the high blood pressure. Okay, high blood pressure. So pregnant mother, we don't know. There is no specific theory that can explain how does the pregnant mother get high blood pressure during their pregnancy, even though before pregnancy they don't have any problems with their blood pressure, but suddenly during pregnancy they have high blood pressure. So you mentioned just now the mother already 7 months pregnant, right? Pregnant, and then you said a fourth baby or 4 times eclampsia. Can you repeat again for that part?
Yeah.
4 times pregnancy.
The mother had 4 seizures in pregnancy age of 7 months.
Or 4 times seizure.
Yeah.
You're not talking about cesarean section, right? You're talking about the seizure itself, right?
Yeah, 4 seizures.
Yeah. 4 seizures. 4 times you mean, sir? Okay.
4 times.
So yes. Okay, thank you. So 7 months having this kind of things lah. The risk between the mother and baby, which one we want to see first? All right. So we want to explain first. You want to know how the baby passed away, what are the causes of the baby's pass away. So when the blood pressure is high inside the body, there will be a condition what we call placental insufficiency, where you know that when the mother pregnant, the blood from the mother will be transferred to the baby. With the blood, oxygen will be transferred as well to the baby through the cord and then pass to the placenta, right? Okay, from the placenta, cord, and then go to the baby. So the oxygen will be transferred from mother to the baby. For the normal mother, there is no problems in terms of the blood circulation from the mother to the baby. But for the mother who have high blood pressure, there will be placental insufficiency, which means that there is lack of blood transfused from the mother to the baby. What does it mean? If less of blood, which means that lack of oxygen transferred to the baby, right? So in the case of the seizure, another complication that can occur is separation, because if the blood is very high, there is a tendency or the chance for the uterus, for the endometrium layer or the uterus or the placenta to be separated from the endometrium layer of the uterus, which means that the placenta that attach the baby to the mother can be separated from the mother. So if this case happen, the bleeding will occur, and then the baby is no longer receive the blood, because the placenta is the place where the baby receive the blood from the mother, right? So when the placenta detach from the endometrium layer, okay, the placenta detached from the endometrium layer, the blood from the mother cannot anymore transferred to the baby. In this case, there's high tendency for the baby to die inside the uterus during the pregnancy. So I explained here 2 things. The baby can die due to the placenta insufficiency, which means lack of blood and lack of oxygen to the baby, and also can die due to the separation between placenta and uterus. We can call also the abruptio placenta. So that's I don't know exactly in your situation because I did not follow the case, but that's the thing that we might want to consider the causes of death for the baby that you have seen. Okay, Fanny?
Okay, Miss.
Okay,
thank you.
Thank you for asking.
Yeah, you're welcome.
Right. Any other question?
Okay, Dr. Siti, the next question is from Jasania Fadina. Right? She asking about how we as nurses deal with the problem in providing caretaking and caregiving to patients who have different culture of competent care from health rules, especially in pregnant women, because in Indonesia the culture is for the pregnant woman should not travel far because it is believed that miscarriage can occur. That's all. Yeah.
All right. That's a good question. Thank you so much for asking. I guess your culture and my culture is not that different, so I can understand very well. So yeah, it's correct that normally during the early period of the pregnancy, we believe that we always advise patient not to travel quite frequent or not to travel very far because yes, it can cause the miscarriage of the abortion. That's correct. That's not the myth or incorrect perceptions. That one is correct. Why? Because we know that during the first trimester, which is the first month of the pregnancy, the implantation of the baby at the uterus is just takes place. Okay, it just takes place. We always advise the mother in terms of how to take care of yourself during a beginning of the pregnancy, not to wear shirts too tight. Okay, we always say like that, not to travel so far because excessive activity will contribute to the bad complications to the baby. For example, if you do excessive activity, do excessive exercise, cycling, for example, during this stage, the baby is so sensitive at this time, so fragile, so we need to take care of that. So that's correct. I believe I cannot see any conflict from the question. I guess we as a healthcare provider should support that during the beginning of the pregnancy, we should say that you should not travel quite far. But when the pregnancy already advanced, okay, when the pregnancy already advanced, like after 3 months, 4 months, then no problem. The mother can travel, no problem for the mother. So these things, sometimes the mother have this kind of misunderstanding because they don't understand or they receive information from wrong people or they got information from wrong sources. That's why they have wrong misunderstanding. So normally travel is allowed after 3 months, 4 months, then the mother can travel, inshallah. Just like a plane, you cannot travel when you are at the end of the pregnancy also, right? Because they're worried you give birth in the plane. So you cannot travel using the what we call the plane now in the end of the pregnancy. But I mean, if you are not yet reached towards the end of the pregnancy, of course you can travel after 3 months, 4 months. Then it's fine to travel. Right? Thank you for the question.
Alright, thank you Dr. Siti for the answer. Teman-teman mungkin ada yang mau nanya lagi? Alright. Mungkin ada yang tanya lagi? Silakan. We are waiting for the question.
Yeah.
Oke, teman-teman, mungkin ada yang ingin bertanya? Sebelum kita tutup. Alright, so I think the students understand with the material gift today, but actually, can I ask something?
Oh yes, of course you can. If I can answer.
So actually, I'm not from the from the nursing background. I'm from language. I mean, my academic is from the language education, and I'm going to ask about sometimes pregnancy women do not accept the right information about pregnancy. So how we as as a people who are not from the nursing background can get the information, the exact information, the true information about pregnancy? Is there any website or something, or we can ask somebody that has expertise in the in the nursing education. You get my point?
Yes,
No?
yes, yes. I clearly get your question. Thank you for asking. So,
Yeah.
so it's really glad to have you here. You are non-nursing background, but you joined the lecture, and hopefully you can get whatever I have spoken today.
Yeah.
Yeah, you get the point. Okay, good. So your question is regarding you are non-nurse, you are not a nurse, but you are afraid if some people they have wrong information about the pregnancy, and you would like to know what are the sources that you can get, right? Okay. So actually it depends on the country, it depends on the culture. Like here in Malaysia, I believe that Indonesia is also the same. We have a website that already created by our Ministry of Health. So we always want to go to that website to get the correct information. There's other information, if you can see the blogs, can if you see the blogs and then personal experience, Facebook, sometimes they put stuff there, but it is really, I didn't say that one is incorrect, but that one is unconfirmed, to say unconfirmed. So if you want to get the real information, you go to the resources that relate to the respective ministry first. And the second, you can always ask around the people who do you know, experts in the area. For example, you have Miss Shanti, you have Miss Dina, who are already experts. I receive lots of questions from my students and my ex-students for their family, for their sister, for their own problems, for their own pregnancy, and even they already get married. Sometimes they text me, sister, what happened if my baby becomes like this? What should I do? So normally they will call me. So yeah, so that's depends. Normally we go to the correct resources lah, right? Okay.
All right, thank you for the answer, because sometimes because yeah. Yeah. Okay, so anybody ada yang mau tanya lagi? Sudah cukup? Okay, I think it's enough for material today. Thank you very much for sharing your material about maternity, especially to me also. I think before we close the agenda, let's take a picture together. So
Wow.
here for the documentation, right? Teman-teman mungkin bisa nyalain kameranya. I'm sorry, before Dr. Siti, could you please stop to share the screen?
Yeah.
Right, thank you. Okay. Right.
Ready.
Right. Oke, teman-teman boleh nyalain dulu semuanya. Dr. Siti, there are 4 slides of the Zoom meeting, so I think we can take 4 times for the documentation so everybody can show
Come
it.
again, what did you say?
Okay, so in the Zoom meeting, there are 4 times to take a picture, I think, because everybody will take a picture too, right? Okay. Okay. Oke, kayaknya nggak ada yang nyalain semua dah. Right. Right, so okay, Dr. Siti, we're going to take the picture, right? Okay, are you ready?
Ready.
Okay. Right. Okay. 1, 2, Sylvia. Mukanya nggak kelihatan atasnya. Ini memang begini ya. Okay. Right. Okay. So everybody, 1, 2, 1, 2, 3. Okay. Wait. Okay, the next slide. 1, 2, 3. Right, sabar. Slide ketiga. Ini nggak ada yang nyalain ya. 1, 2, Right, slide terakhir. Ada yang lain? Satu. Alright. Okay. Alright, Dr. Siti, thank you very much for your sharing today. We hope that the students from batch 2019 can understand and can get the positive knowledge from you. Thank you very much. Terima kasih semuanya yang sudah join hari ini, juga untuk pertanyaannya. So, mari kita tutup. So we can let's close our agenda today by saying Hamdalah together. Alhamdulillah. Okay. Thank you very much, and bye-bye. Bye-bye.
Bye. Thank you, everyone.
Thank you.
Thank you.
Teman-teman jangan lupa isi attendance-nya ya, yang sudah di meeting chat.